Welcome back to Learning Plan 5. This is Part F. We're going to be covering angina and myocardial infarction in this part. So angina is the pain that is caused by not enough oxygen getting to the heart, specifically the muscles of the heart. It can be caused by a lot of reasons. Most commonly, it's from a blockage. Usually when you get to about 75% of an artery blockage, that's when angina starts to occur. It can also happen from vasospasms, significant vasospasms. It can happen from dysrhythmias, anemia. So there's many reasons, but most commonly it's a blockage. Ischemic heart disease is the #1 cause of death in this country. It's the primary cause of that disorder is coronary artery disease. Now this usually is caused from atherosclerosis. Remember we talked about that? That's when the vessels become hardened due to the buildup of plaque. We talked about that when we talked about lipids. It creates a decrease in the ability of the heart to get oxygen. And of course every cell in our body needs oxygen to survive. When the heart cells do not get enough oxygen, they begin to send out signals, pain. When that goes on long enough, the pain leads to those cell death, and that is truly the infarction. When the cells start to die, that is when you have true myocardial infarction. When the cells are deprived of oxygen, they switch from aerobic metabolism to anaerobic metabolism. This creates more lactic acid, which irritates the pain receptors around the heart. So angina it happens more frequently in females than males, and it's the highest in African Americans. But everybody can get it, regardless of race, national origin, gender. We can all get it. So angina is the pain. Angina pectoris is actually pain in the chest. Myocardial infarction is when the heart cells begin to die. So the basic disease process that leads to the myocardial infarction, or MIs, is atherosclerosis, or hardening of the arteries. A plaque is a complex structure made up of cells, cholesterol, and other fatty substances, that waxy buildup that blocks those arteries. Remember the model. There we go. That was the word I'm looking for. That model we had in class that showed what it looks like when an artery has that fatty buildup in there. Eventually, those buildups become big enough that it starts narrowing the channel that the blood passes through. The pool of the fat, or the lipids, within that plaque is covered by a thin fibrous cap. Now that cap may split or fracture, exposing the blood to elements within the plaque that stimulate blood clot formation. This is important, and we're going to get to blood clotting later in this lecture. Now, okay, remember we have that cholesterol plaque, and the body creates a fibrous covering for that plaque. Remember, we always want to make the body is trying to make the interior of that blood vessel slippery, and that plaque isn't. So that fibrous tissue is slippery again. But that fibrous tissue can rupture. When it ruptures, the blood cells hit that plaque and start to form a clot. That clot can happen very quickly, and that begins to acutely block the artery. And if it happens for more than a few minutes, cell death starts to occur. Because remember, we can only survive a few minutes without oxygen. Same thing with our heart cells. So how do we treat that? Well, when a person has angina on a regular basis, we can treat it with 3 different types of medications: nitrates, calcium channel blockers, and beta-adrenergic blockers. And we've talked about these previously. We're going to cover them a little bit more now. The primary ways that these anti-anginal drugs, the way they work is to reduce the myocardial demand for oxygen. This is accomplished by at least 4 different mechanisms. We can slow the heart rate. The slower the heart pumps, the less energy it needs. We can dilate the veins and arteries so that the heart receives less blood, which is reducing the preload. We can cause the heart to contract with less force or reduce contraction. And we can dilate the arterioles to lower blood pressure, and which gives the heart less resistance when ejecting the blood, which is reduced afterload. Okay, remember, slow the heart rate. That will be a chronotrope. We're going to dilate the veins so that the heart receive less blood. That's a dilator. We're going to create the heart. We're going to have the heart contract with less force, or an inotrope. And then we're going to dilate the arterioles, another vasodilator. Nitrates, beta-adrenergic blockers, calcium channel blockers perform these functions. Nitrates, these improve the venous return and coronary dilation. So nitroglycerin is the classic nitrate. And isosorbide dinitrate, or isodil. Now, I want to point out something. Isosorbide dinitrate is different than isosorbide mononitrate. So if you're taking down your notes, if you're writing down what the patients are using, if you just write isosorbide, that's not a drug. You need isosorbide dinitrate or isosorbide mononitrate. I learned that the hard way when I was taking down my notes, and I was talking to the doctor, and I told the doctor they take isosorbide, and they said, which one? And I went, I'll get back to you on that one. So don't make that mistake. So nitrates, they improve venous return and coronary vasodilation, and they work very fast. They're short-acting, but they will quickly dilate the blood vessels, causing a rapid drop in blood pressure and eased blood flow. Beta-adrenergic blockers, beta blockers, decrease heart rate and contractility. The two most common are atenolol, that's the generic, brand name is Tenormin, and metoprolol, or the brand name Lopressor. And remember, these slow the heart and reduce contractility. And then we have calcium channel blockers. These are vasodilators, and they decrease heart rate and contractility. So they kind of cover everything. Diltiazem and nifedipine are the two most common drugs for use for those. So let's talk about nitrates. Nitroglycerin, or nitrostat, nitrobid, nitrodur, there's many different brands, but they're all nitroglycerin. And then we have isosorbide dinitrate. These treat angina. Nitroglycerin is short-term. You can also take it long-term if you use patches. The nitroglycerin patches are commonly used for long-term treatment, but some people use it under the tongue. It's a little sublingual tablet, goes under the tongue to dissolve. There are also sprays that can be sprayed in the buccal membrane of the mouth. These relax venous and arterial smooth muscles. Vasodilation makes the pipes big, and it decreases the myocardial oxygen demand. Side effects, you can develop tolerance to this, so then you need more to get the same results. It will cause hypotension. So you need to be careful. If you're giving this in the hospital, what do you suppose you'll do before you give one and then after you give it? You're going to check a blood pressure. And if it drops precipitously, you're going to consider not giving another one. What's precipitously? Well, it depends on what the initial blood pressure is, but when you start getting below 100, you're going to start thinking very carefully, do you need to give another one, or can you give another one? It will cause headaches. That is a classic side effect because the dilation happens everywhere, and the dilation of the blood vessels in the brain cause increased pressure within the brain and a headache that will mimic a migraine. I've tried this one time, I needed it one time, and my goodness, it gives you a blinding headache. Actually, I tried it twice. One on purpose, one accidental. Ask me about the accidental in class, okay? It's a cute story that I hope you never do. It causes dizziness, weakness, and syncope strictly due to the low blood pressure, and increases intraocular pressure and intracranial pressure. Again, the dilating the blood vessels in the brain causes increased cranial pressure and increased intraocular pressure. Short-acting is sublingual, Long-acting would be transdermal or PO. Isosorbide dinitrate is long-acting. That's a PO. You take that as a pill. You can give this through a vein, IV, and that has very rapid acting, and it can be used long-term, titrating up and down as needed. You would only give nitroglycerin in a critical care setting, an ICU setting, ER, OR. You're not going to give nitroglycerin IV on a med-surg floor. So some questions. Why use different routes for this drug? And how often can you give the sublingual nitro? Why do we... Okay, so when you're giving nitroglycerin, there's different routes for different purposes. Obviously, short-acting is for acute pain. If you're having a chest pain right now, you take the sublingual or the sprays. If you want to prevent chest pain, you'll take the isosorbide dinitrate for long-acting. How often can you give sublingual? Generally, every 5 minutes for 3 doses. If they tolerate with your blood pressure. Where do you apply the patches? Well, where do you think we're going to apply patches? Let's talk about that in class. Why do we remove those nitro patches for 12 hours? Again, let's talk about that in class. The nitro headache is actually good. It's telling you that the blood vessels are dilating. So it's actually positive proof that it is having the physiological effect in the body, or the pharmacodynamics in the body that we're looking for. It's a headache, but we're taking this for chest pain, and that chest pain can kill you. So the headache is a lower risk problem. When would you be cautious about giving nitrates for chest pain? Well, think about those commercials we see on TV. Those erectile dysfunction commercials can have a very large additive effect on blood pressure. If a person is using erectile dysfunction drugs and they need nitrates, they could have a huge drop in blood pressure. Beta blockers, again, these are beta blockers that slow the rate of heart. They'll slow the heart rate. They have a negative inotropic, chronotropic, and dromotropic effect. They decrease the conduction velocity through the AV node. So they slow the heart, they make the heart beat less hard, and so decrease conduction, decrease the rate, and decrease the pump pressure. These are used for angina and dysrhythmias, and they're usually used to prevent this, not as a treatment after it happens, although it can be given IV for treatment acutely. But if you're taking this in oral form, this is to prevent problems. It affects the CNS, the central nervous system. It causes dizziness and lightheadedness. It can cause respiratory bronchoconstriction. So remember, this would not be given to a person who has problems with asthma. Hypotension and bradycardia. So you can have very slow heart rate and a very slow heart rate and very low blood pressure, and weakness and fatigue due to that. This is used most effectively when a person is also taking nitroglycerin or nitrate in some form. Calcium channel blockers reduce myocardial oxygen demand, and again, it sometimes can benefit by using nitroglycerin and beta blockers in conjunction. Again, using smaller doses of everything to achieve the same results. Again, calcium channel blockers reduce the passage of calcium into the vascularly smooth muscles. So it has a dilating effect on the peripheral and coronary arteries. It has all the same effects of the other medication: dizziness, fatigue, hypotension, headache. Respiratory depression or arrest can happen. So you'd always want to evaluate respiratory function. Peripheral edema from the peripheral vasodilation. Heart failure can occur. And if a person has digoxin toxicity, you would not use these medications. So nitrates, beta blockers, and calcium channel blockers are used for treatment and prevention of chest pain and angina. Powerful drugs. They can also be given preventatively to prevent this. You'll be using these a lot in your career. You need to know how to assess for problems, how to assess for the side effects, how to assess for the therapeutic effects. And sometimes the side effects are indicators that they're having a therapeutic response. Remember that headache, when you're giving a nice treat and you get the headache or the person gets the headache, that's actually a positive action. So that's it for the angina and MI part of this discussion. Come back for blood clotting. It is an important and somewhat complex topic. We're going to talk about this and just discover the importance of preventing clots and preventing worsening of clots. Come back for part G.